signed by the chief.
All right. Well, we'll get started. Of all the crews, you guys probably are more in the know of part of what spurred this training, because we're on this shift, and maybe word's got out, maybe it hasn't, I don't know. But it's gone well so far. It's been well received. It's been something that I think was probably a necessary reminder with a couple of changes on a couple of things. We're going to talk about a couple of new guidelines that we have in place. They're pretty set, but not completely set. So if you have some thoughts as we're talking about them, things that can make it better, or maybe something that we hadn't thought about. It's gone through Jason, it's gone through Dr. O, we've reviewed it. Back to Jason, back to Dr. O, kind of that whole process. But in the end, Dr. O has felt pretty strongly, and rightfully so, about his position on these things, and I think it makes us better. And so we'll talk about those things as we go. But what this is really about is not really so much an IV pump operations class as a process or procedure for us when we are taking people on pumps. And what spurred this, if you haven't heard, was about a month ago, we had a medication error, and it fell on my shoulders. I made a mistake. And so on discovery of that and everything that we did afterwards, and Mark felt the same. We were partners that day and said, hey, this is probably something that we should share with everybody and learn and get better as a department for. So I'll just kind of tell the story of what happened. We know why it happened. I know exactly what I did. I know how I made the mistake, which is good because it's fixable. But it was something that literally a week later, we had a paramedic with us that was not on our shift, that was working, and I had told them about what had happened. We had almost nearly the exact same patient, and this paramedic set the pump up exactly the same way I did, which was wrong. And so, obviously, it's a bigger issue than maybe just one of us, right? On top of that, our med error came on the heels of a similar med error, a different drug, but another medication error with the pump that happened just a couple of weeks earlier. So with all of that, Dr. O was like, pump the brakes. There's a problem. We have a problem with our system. Let's get it fixed. So what had happened on this go around? We were called out on an ALS transfer on a pediatric patient that was on two IV drips. One of insulin, one of D10. This was the second pediatric diabetic patient that we had that go around. First one was on insulin and potassium, and it went flawlessly, and everything was set up right, and went well. So you think we probably went in with a little bit of confidence, right? Hey, we just saw this yesterday. We're good. Okay. Mark was the primary paramedic. He was given the primary care, and like we do so many times, he took a pump, said, hey, I'll set up the D10. I said, great, I'll set up the insulin. And we went to work doing our respective tasks. Knowing that he was taking the patient, I asked him, because I think most of us have done this at some point, and maybe not. If you haven't, good for you. But I asked him, do you want me to set this up in volume, just the rate, or do you want me to set it up in the weight-based dose? And he said dose, and I said good, that's how I like to do it too. So I looked at the pump, and I had in my mind, I'd looked at the rate, which was 3.5 mils an hour, and then I went from that mindset of mils per hour into the dose. And the dose was actually 0.1 units per kilo per hour. And guess what my dumbass did? Got a guess?
3.5?
Yep. Which is a massive
units
overdose.
per kilo per hour?
Massive overdose, right? Massive. 0.1
300 times.
to 3.5. So, set it all up, primed the pump, had it ready to go. Said, Mark, we're good to go, the pump's good, handed it to him, and he's ready to take the patient, and I'll let you kind of take his part from there.
Right, and so I took the pump, and I trust Kyle. I still trust Kyle, right? We've been working together for a few years now, and he knows his stuff. I know my stuff. He handed me the pump, said it's good to go. I had no reason to doubt that it was good to go, but that doesn't mean I shouldn't have verified the settings on it, right? So I set up the D10, and they just had that one in mils per hour, right? It was 148 mils per hour on the D10. And so that's how I programmed it on my pump, was just in a rate, 148 mils an hour. So I looked at my pump, and it said 148 was the big number on the screen. I took Kyle's pump, took a quick look at it, saw the 3.5, thought it was good to go because, well, mine shows in mils an hour, the 3.5, the big number on the screen, should be mils an hour. But because he'd set it up in a weight-based dose, that 3.5 was 3.5 units per kilo per hour, and the mils per hour was up in the top corner, and I just didn't look at it close enough.
So obviously a breakdown in our system, right? The crazy thing about that is, and I've been my practice, I learned it from Jason and Jeremy and all the guys that came before me that were my mentors coming up as a medic. Every single time I take a medication out of our box, even if it's something that is seemingly harmless like Zofran or Narcan or something like that, we know we're not going to really do damage to this patient. I always pull it up, I read out loud what it is, how much I've got, when it expires, right? Go through my rights, show it to my partner. Mark, I got 4 Zofran, 4 and 2. This is the date. He looks at it. Yep, you're good. Pull it up. Okay, I've got 2 mils. Yep. And I've done that, and that's been my practice forever. And why I wouldn't do that same thing when I'm taking a pump with a medication that I didn't, even more so, it's a medication that I didn't set up, that I didn't take the time to do the initial infusion of. Even more reason for us to verify that those settings are correct. And so, why I didn't do that, I don't know. But let's move forward a little bit here. We get the kid to McKay. He's had a precipitous drop in his blood sugar, as you would guess. Luckily, he was on D10, which is probably part of the saving grace of this, is he was getting some sugar into his system as we're draining it as fast as we possibly could. This initial, the way that it was set at 0.1 should have taken almost 48 hours to deliver. It was almost gone by the time we got to McKay. And we'd invited Jeremy up that night to have dinner with us. We're sitting around the table. Jeremy gets a text and says, hey, he gets a text from Jason, who'd gotten a text from Jen Chatterton and McKay, and said, is it possible you guys had a medication error on that diabetic? And my answer was, no. No, I looked at it, I checked it, Mark looked at it, we're good, I'm quite certain. And then it registered in my mind that those pumps have the repeat last infusion option. And I thought, hey, we haven't used it again, I'll just run out and check. So I went out, pulled it up, repeat last infusion, and my heart just sank. Because I knew that fast. I was like, oh shit, we overdosed this kid in a big way. Went in, Jeremy probably felt the disappointment and stupidity that I was feeling. I told him, hey, I screwed up. We overdosed that kid, definitely had a medication error. Jason was kept in the loop through text, and I immediately went in and sat down. And this is part of the process that I want you guys to learn, is that medication errors happen, okay? They do happen. We do our best to make sure they don't happen, which is why we're having this training today. But when they happen, own it. The minute that it's recognized, own it, take corrective action if you can. If it's beyond the point of that, which ours was, then get the ball rolling to do whatever we have to do to fix it. And part of that first thing is recognizing, okay, it did happen, own it, don't try and hide it, don't bury it, anything like that. So I typed up an email. Jeremy was still up there, he read through it, I sent it off to Dr. Rowe, Jeremy, Chief Cook, and Chief Mon. Dr. Rowe told me that he read it that night from his home, read through it, and by the next day, I think we had a meeting set up for a couple days later. Dr. O was going to come down, Mark, myself, and that whole group of guys sat down and said, hey, what happened? What I want you to know, well, first of all, I'm going to back up. Outcome for this kid. Thank goodness. I keep expressing this. If you've heard me say it, sorry if I'm boring you, but I wished I could take what I was feeling out of my chest and put it in yours, because it was the sickest, most horrible, heaviest feeling I've had in my career here, honestly. The thought that I could have taken something that I did. What's the first thing we learn in EMT school? Do no harm, right? And now I've taken this kid who's supposed to be getting better, who looks at us and trusts us, and because of my complacency I had the potential to really do harm to this kid. He could have died, could have had swelling on the brain, could have had a number of things that could have gone poorly. I was literally in tears in my bathroom when I got the text the next day from Jason that, hey, the kid's okay, he's gonna go home today. And I didn't feel like, oh, whew, I still, to this day, I feel horrible about it. I feel horrible that I put that kid in that position. I feel horrible that I put a receiving hospital in the position to have to fix my screw up, you know, on this kid. So there's no way I can do that except to tell you, I hope you never have to. It was a horrible feeling. And so luckily for us, I called Mark immediately after I got the text from Jason. Mark was at his second job, and I was like, dude, the kid's gonna be okay. And I could hear his relief through the phone. I can't remember if I called Jeremy or texted him, but I let Jeremy know, like anyone that was in the loop. I just made sure that they knew kid was okay. We got lucky. And Mark said it very well. We don't want our patient care to be based on luck.
Ambulance 533, response to 31 Zulu, unconscious at 222, Drive, number 19.
So we got lucky, but that's not the way we want to practice medicine, right? Maybe a little bit of luck now and then, but we don't want to put ourselves in a position where we're relying on luck. And at that point, we got lucky that this kid did as well as he did. So, a couple of lessons learned. One, medications are no joke, right? Mark Hoyt referred to it as we take some of these patients out on rocket fuel when we're pumping it into their system. And the smallest adjustments can make huge differences. Division, you good? Oh, thank you. Go get him, paramedic student Corey Ellison.
Do you need our pumps, Capt?
No. It was kind of like a pump operations class, but we're not actually going to get into the functioning of the pumps today. More just this, we'll talk about this process. But anyway, anything you want to add about the experience itself?
Right, just, yeah, that whole luck thing, right? We're lucky that the receiving hospital caught it, right? They recognized the error, they had the ability to fix it, right? It was a huge relief when we heard that the kid was okay, but that doesn't mean what we did was any less serious, right? And we're hoping with this training that we get some of it out there so that it doesn't have to happen to you guys, that we don't have to rely on luck for our patient care.
Having recognized it when we did and getting right on top of it, I was really actually glad Jeremy happened to be up there that night. It made that process go smoother. But if aside from what we're going to talk about the procedure, Jason said it, he would say it again today, medication errors happen, right? They happen to doctors, they happen to nurses, they happen to medics, EMTs. We're human, we make mistakes. We try to do everything we can to limit the potential for those mistakes, but when they happen, own it quickly, get it resolved, and I can promise you, these guys handled it in the best way possible. The best, there was no, what the hell were you thinking? There was no, pull your head out of your ass kind of stuff, all the stuff that I was thinking on myself anyway. But just, hey, you made a mistake. How did it happen? How can we make sure it doesn't happen again? How do we get better from this? And that's what kind of has led to this revamping of this guideline. So we'll pass it out to you guys. We want to go through it. Any questions on anything so far? Comments? Okay.
Yeah, I think just to throw one point out there, and we talk about the process and how it was received and everything else and how it was dealt with. I think that's, well, that's kind of what we'd expect, but that's largely due to both of your perspective and, you know, throwing it out there and being willing to learn, being willing to give classes, everything like that, and I think we'll be better in the long run, but I think that's also attributed to, you know, both of your, way you handled it.
I appreciate that. That could be nothing but humble after it happened. Like, well, you know what I mean? What else could I say? And I would hope that none of us would ever be defensive in that situation. or try and defend a bad position, right? Because that's a losing proposition for all of us. I've been doing it for, this will be my 22nd year, and 17, 18 years as a paramedic, and it's the first medication error I've had. I've had some other, I almost killed a lady once with some fentanyl. It wasn't an incorrect dose, but yeah.
What a great call that was.
But things happen, right? And we recognize them, and we fix what we can fix when we can, and when we can't, we own it and we get better. And we fix our process if that's what the problem was. And in this case, we did not follow good procedure, right? And so what this guideline is for, I'm gonna have Jason just kind of explain a little difference between a protocol, a policy, and why this is written as a guideline.
So, in legalese, policies and protocols tend to be viewed much more rigid. They are kind of, you will. Guidelines recognize that there's flexibility, that the reality of it is that we operate in a shade of gray. Very seldom is it that everything's black or everything's white. And in our world, it's usually a dark shade of gray. So we wrote this knowing that there are certainly gonna be occasions where this may not fit. Now, that doesn't mean invent an occasion to make it convenient for you at the moment. But we recognize that there are always outliers, there's always circumstances, and so that we didn't want to tie anybody into a position of, oh, I'm gonna get in trouble or anything else. Now, as a guideline, it's still the foundation for what we expect for all of us, right? But the point of the guideline is this is meant to be kind of a systematic approach to how we're going to approach those patients that have infusions running, or that we start. Kyle mentioned the other day that we do occasionally start Levophed or whatever in the field if we have to. And so we need to be very deliberate, precise, and the word I've used is intentional. You heard Kyle mention, and I think it's true of the whole department in a few other ways. We've gotten a bit complacent. And I could evidence it in several ways. I think we're complacent sometimes in the way that we drive. I think we're complacent sometimes in the way that we do or don't do our checks. I think we're complacent in, frankly, our documentation and our paperwork a lot of times. And it's easy to say, well, we're busy, or well this, the whataboutism or the justification that we tend to do for cutting corners is easy to do. And I'm not saying it as somebody that doesn't do it myself. I'm as guilty of it as all of you. So I think as an organization, this was a wake-up call. It was kind of the heralding or sentinel event to finally say, like, I've described it to everybody as we're kind of in an, we're not kind of in it, we are in an FAFO business. Do you know what that means? Fuck around, find out. I don't want any of you to FO. Okay, and so if we hold one another maybe a little bit more accountable when it's go time, if we put our game faces on just a little bit, hey, don't get me wrong, I want you to play and play hard. Nobody plays harder than the 53 crew at Station on Alpha, believe me, right? But game face when game face has to happen, and this is certainly one of those occasions, and if I can just piggyback another thought. We're one of only 2 or 3 ground fire-based ambulances in Utah that have been entrusted with and have, as a matter of practice, transporting very sick patients on vents, IV infusion pumps, to level 1 trauma centers, level 2 trauma centers, immediate cardiac interventions, whatever. Almost everywhere else, this is a flight team that's entrusted to do this, right? So it's a hat tip to all of you and to all of us that we have an organization and a physician advisor and the EMS community that trusts us to do this. But with that trust comes responsibility to do it to the best of our ability. And like Kyle said, we found out system-wise, not anybody, right? System-wise, we needed to readdress it. So that's why the guideline, please follow it as closely as you possibly can, because doing so makes us better, but, well, not it makes us safer for the patient, which is the #1 priority, which then necessarily means it makes us better. We're better as a department doing this, so, okay.
Okay. These, there's a couple of like highlighted areas. They're kind of hard to see, but if you'll see starting under definition, those first 2, we're just kind of hit those. I'd say captains, but there's only me and Rox in here. 54, go through this. You should have one sitting up there. I'm sure you do from the other classes. If you don't, we'll get some to you. But starting there under definitions. So for the purpose of this policy, the standard of practice, all medications and or fluids being administered via an infusion pump are considered critical care medications. We sat when we talked about this and said, you know, especially these critical meds, and they're like, well, how do we break that down? What does that list look like if it's critical or it's not critical? And Dr. Rowe, and you know, to his credit and wisdom, said, look, if it's important enough to be on a pump, and whether it's even just a fluid infusion going in, but we're really trying to monitor the amount of that fluid, doesn't matter. That's critical if it's important enough that we placed it on a pump. Does that make sense? So any medication that's being given through a pump is considered a critical care medication. Any questions about that? Concerns? Okay. And then again, for definition, the primary paramedic provider is the paramedic that's ultimately responsible for the patient care during the transport. And that's just for definition as we continue through the policy. We're going to jump up to considerations, where the next section that has some highlighting, and we'll let Mark kind of go through that.
Right. So the first one just specifies, right, using the IV pump, we just talked about, is paramedic skill. And so a paramedic should be the one programming that pump, right? It's not that we don't trust our AMT partners or anything, but same thing, the way we talked about earlier, for intubation. It used to be the advanced EMTs, the intermediate EMTs had the ability to intubate. But when it comes down to it in a full arrest for an RSI or anything, it's going to be a paramedic that's going to place that tube. So the same thing with this policy. For a critical care medication being infused through an IV pump, we're going to have a paramedic program that pump. And that's not to say we can't do training on it at the station. It's not to say the EMTs can't be watching over our shoulders, helping us kind of get the numbers right as we're programming it, but the pump will be in the hands of the paramedic for the programming.
And it's not to discredit our advanced people. A paramedic, me, is the one that made the mistake, right? Not an advanced. It wasn't because of lack of training or a lack of schooling that all you advanced have. You're all amazing at what you do. And we appreciate running with you, and I appreciate every call we go on together. But it's just that important. The person who's delivering the care is going to be the one that's programming the delivery of those medications.
The one under that, it's not highlighted, but we did want to touch on it. Right? When possible, we're going to use the drug library or other smart pump functions to reduce the chance of the medication error. And we understand that the drug libraries in the pumps aren't as up to date as they should be or could be. Captain Hoyt's working on that. He said that there was a big system update that erased his drug library off his computer, and he's been working on reprogramming that so that he can get it on these pumps. Should be out in the next couple of weeks. So just to mitigate those errors, right? Obviously insulin wasn't on the pump when we had our error. It should be after this next update, but hopefully with using the drug library, it sets parameters so that we shouldn't be able to put 3.5 units per kilo per hour. The pump should recognize that that's way too much for the drug we've selected.
And something to keep in mind on that, there's gonna be some things, Luke was actually one of the guys that said, man, it'd be nice to have this, but it's also going to make sure you need to be on your A game. There will be different varying concentrations. For instance, norepi, maybe in 16 mics, might be in 32, 64, whatever. So you're gonna have to really verify on their bag and the pump that you're making sure that your concentration is set correctly to what the bag is that you're actually hanging. That's gonna be, which we should be doing anyway, right? We should double and triple check that before we go. But the pump will actually have those varying settings of those concentrations built into it. So make sure that you get in and you train with that. I wanna say play around, but not play around with it, train with it. And make sure that you know that so that when the time comes, and it sounded like he was maybe a week out or something.
I've been leaning on it very hard, and so I'm hopeful that it'll get wrapped up this week, but very, very soon.
Did he happen to say if he's gonna get rid of that extra, is it like A or something like that in front of it, so it limits the ability to just search the meds straight away? You know what I'm talking about?
I do know what you're talking about, and we haven't had that conversation, so
Yeah, I hope that drops on the line, that makes it a little more difficult, but.
Share that with them. If you haven't, make sure to share it with them, so.
I think all of us would agree, I think these pumps are awesome. Like compared to the old triple channels that we had, where you had to like massage the bubble on the cartridge and you'd get error after error, like, I'm grateful for the pumps, they're fantastic, and they let us do our job in a much more efficient and better way. But we're just getting some of the kinks worked out and getting them dialed in, and they're gonna be more functional, more useful to us with this last update.
I'm gonna just add something, and if Jeremy, you'll share with the 53 crew, or you can. Probably the only pushback so far has been, hey, you know, like I'm really used to just being able to look at their rate, their flow rate, the volume that's infusing through there, right? And just match that rate. I had a very veteran, very smart paramedic say, I've done that thousands of times and never had a problem. And I said, no, that's absolutely true, until you have a problem, which is exactly what happened in this circumstance. And so, you know, he said, but I'm so much faster that way. Well, let me address that first of all. We've developed this mindset that we have to rush through these transfers. No, we don't. And in fact, the sicker they are, which by virtue of the fact that they're on rocket fuel on a pump means they're sick, we need to be efficient, certainly, and maximize our efforts, but we don't have to rush through things. And this person said, well, I can program a pump so much faster. And I said, you know, I don't run with them every day, but I do know the pumps pretty well. And you can't show me that it takes more than 4 keystrokes in the pump to enter it with the drug library in a dose weight-based calculation like our doctors directed us to do, than it does for you to just enter it as a flow rate. And I said, if those 4 keystrokes take you more than 2 minutes, I'll kiss your bare white ass. And he relented that.
Now we all know who it is.
He relented that, yes, it was only a few more keystrokes, and begrudgingly admitted that it really wasn't a time saver. So, you know, what it was convenience for him. It was that complacency for him. And he finally admitted that and was great about it, so I'm not worried about it. But, you know, Kyle started this off with the notion that we do have to have a practice change. And for those of us that are programming, the medics are watching those that do, it's pretty emphatic that we will be using the drug library if it exists. Again, shade of gray, right? There's gonna be those occasions that it doesn't, right? I know that. But if it exists, we will use the drug library.
And I think we're bound to come across maybe some programming things as we use the drug library, make sure we go through the channels, get it to Mark, we'll get it fixed, get it corrected, and get them dialed in where they need to be. But ultimately, that's gonna be the safest way for us to do these medications. So, Brayley, you're a new medic, you've had a chance to probably use the pumps from time to time. What's the advantage to you as far as your patient care goes of entering that in as a dose-based or a weight-based dose rather than a volume?
If it's a weight-based dose, it's a lot easier to adjust. If I've got it running at mils per hour and I need to fix it now, I have to go through a whole new calculation, and
That's the big one, right?
It's math at 2 in the morning.
Right.
That sucks.
that's gonna be an error.
Right, it is. It opens the window for one more thing to cause an error. Where we're on a very specific weight-based dose given to these patients and we're set up that way, it makes making those adjustments more accurate, more timely, and less of a chance of making a mistake, right? So it really just makes sense that the 2 minutes that you might spend extra on the front end will probably save you 5 to 10 minutes on the back end if you need to make a change in the patient's medications while you're en route. So
I think we've seen, don't spend more than 2 minutes.
right,
Or I
'cause they-
might pucker up. Or I might pucker up.
exactly. So the goal is keep it under 2 minutes.
I think one of the barriers to that, doing the calculation is one, and I think this is mine, because I find myself doing that all the time when we're switching them at the other place, is the biggest one is laziness, and then the second one is familiarity with it.
Mm-hmm.
Because as you know, if you're not totally familiar with that pump calc or pump calculator option, like, it throws your head for a freaking spin if you're not, you know, aware of what each of those areas are.
Mm-hmm.
And so really it's a familiarity thing.
Yep.
So, you know, if you're defaulting always to just setting a rate and going, then maybe you need to dive in there a little bit.
Training issue, yeah, for sure. Spend some time, and that's what we said, spend some time training with your crews, with yourself, with the pumps, and just get to where it's some muscle memory there, and you're comfortable with setting those up in the dose-based.
Plus another thing in support for the calc option, more often than not, if you're just copying drips, you don't know what dose they're giving, right? You're just mirroring what the hospital has. And quite often, you'll find that as you start getting in what the actual quantity of med is, what the rate is, all that kind of stuff, you're gonna see what the dose is, and you're either gonna recognize that as, you know, correct or incorrect. Plus, it gives you more familiarity with what the common doses are, and it's just better all around, right?
Well, and I'll add too, I've added this a couple to both the other days. I'm sure Jeremy or Lucas had this occasion, but if so Brayley, I'll give you an example. You get a pass off from a nurse that says, this is running at such and such mics per kilo per minute, and this is running at such and such mics per what hour or whatever, right? Units per hour or whatever. So you're like, okay, great, thanks, and you write it down, you know, being diligent like you are with your hand up. And then if you go into the room, you'll have an occasion in your career where you'll be like,
Nope.
that's not the same. That's not the same. And so if you mimic what's running, contrary to what they've told you, and now you go to the receiving hospital, and you're like, that's running at, and they're like, no, it's not. Shit flows downhill, you're all plumbed. Who gets shit on first and last? That begins and ends with EMS, I promise you. It's never that the sending hospital did it wrong, it's that we did it wrong. So when you do walk in and you're like, hey, so you go back out and you're like, psst, psst, come here. You mentioned this, but I see this. Like, oh shit, right? Now that's their med error to deal with, right? And that does happen. You nodded your head, right? It does happen. So it's another fail-safe for patient care, but it's another thing to make sure that doesn't you don't get hooked with that, all right? So it's another thing that, you know, Jeremy mentioned this, and it's worth repeating, and this isn't an indictment, the two medication errors that happen that I know of, and by the way, I'm sure there's those that we don't, totally understand that. But the two medication errors that happened with senior people, right? They handled them perfectly, in both occasions, they handled them flawlessly. All right, I keep saying I could kiss people, but I could kiss people about the way that they handled them. They did it perfectly. But having said that, these weren't new paramedics. These were veteran paramedics that for what, you know, Jeremy mentioned laziness. I've used a pump that way at the other place, being lazy myself, knowing full well it could bite me in the ass. I was on a med error on a pump with a patient with a nurse that my partner put the patient into cardiac arrest with their med error. So they're serious, and that was a complacency, lazy thing too from a very veteran provider. So that goes back to what I said before. We gotta be on our A game a little bit, we gotta step up a little bit, so.
One of the things while we're talking about that, Jason made mention of this on our second training of this. We sit there with our iPad and everything. Great thing for the advanced to do before we do it is take that iPad, go in, take a quick picture of their pump, the way that it's set up. Have that on there. That way, if there is any question, when you get to the receiving facility or you've got any question, we actually have a record of, no, it was set at this. This is their pump, and that's what it was set at. You know that they scroll, and you can see the medication name, you can see, so get it to where you can capture a picture of that medication and what it's set at, and have that as part of that record. I think that's a great idea, and kind of it's not a fail-safe, but it's just one more layer of protection to have, for us. And
that's one of those things that if you're an A, you can say to it like, hey, do you guys want me to shoot a picture of that real quick? Or, better yet, hey, just so you know, I took a picture of the pump for you.
Yeah.
That's one of those things that you can do that adds to our quality, it adds to our patient care, and is a very easy thing to do. All right, those iPads afford us to do a lot of things that we've not done before, and that's such a quick, easy thing to do. So it's not in here, it's not practice, but I would make that a matter of practice if it were me. So.
Might be a
I'll
little-
mention that it scrolls across on their pump, right? But there's also a little white button. There's 4 buttons on the front of the pump. The one at the top says channel select. You hit that one, and that big screen in the middle, it'll pull up all of the information on that particular infusion.
I'm glad you mentioned that, because a lot of times people think that on each channel, it shows you the dose. That's actually just the mLs per hour.
Yes, that's just the rate.
So like, I think that's something when I had to learn when I was programming pumps. I'm like, wait a second, it's not the dosage, because
That'll mess you up too.
And those are the very little things that can come back to bite us, right? And so, it's just one more layer of, hey, we did take a picture of it. If there is a question when you get to the hospital, you can turn your pad around and be like, there's their exact pump that was set before we picked them up. And like I said, the more that we do that, the more that we become more familiar with the medications that we're taking, because anybody here ever taken a medication you had no idea what it was? Or how it worked? Or maybe I shouldn't have been taking that patient? We're gonna get into that later. But it happens, right? And so making sure that we've got some of that information is a really great idea for the record on that patient. So let's keep going, Mark.
Yeah, so the next highlighted section just shows that primary paramedic provider should cross-check all medication infusions with another provider, preferably the sending facility staff, either a nurse or the physician, or another paramedic to reduce the chance of errors, right? Like Kyle mentioned earlier, we do it on every other medication we pull out of the box. We should be doing it on our infusion pumps also. Right, hey, this is what I had programmed to, this is my concentration, this is the rate, this is the dose. Does that sound right? Rather than, hey, it's good to go, right? And then this last bullet point, right? Program the pump primary provider should eliminate distractions, right? With everything else we do, right? If we're intubating, if we're doing anything else, critical care, we're focused on just that, right? We're not trying to run the show and do skills at the same time. We're gonna eliminate all distractions there at the hospital too. Sometimes we walk in, there's 4 family members, the nurse is trying to pack belongings in the bag and hand it to you. There's all sorts of other stuff going on. Their vents getting swapped over at the same time. So if you're in charge of programming the pump, you're gonna take that pump and just eliminate all that other stuff, right? Take it right over to their pump and program it, take it out to the hallway if you need to, so that you can focus on what the numbers are that you're programming.
Yeah, and again, just like we went back in the ambulance, I hope that we're not like willy-nilly pulling up medications while we're laughing and having a side conversation, you know what I mean? We're focused in on that medication, we're looking at all of our rights, we're double and triple checking the amount that we've got, the dose that we've got, and we're trying to kind of create that sterile cockpit. So, as the partners of somebody, if you can see that your partner is setting up a pump, and you've got a question, let them finish what they're doing first, don't distract them. Let's help each other to kind of keep and create that bubble around them so that they can safely program those pumps, get them correct, and then we can have that conversation once it's programmed and done. All right, we're gonna jump down to procedures, which is really, we're gonna hit on kind of the documentation, the third bullet point down there. We will clearly document the medication orders, including the medication name, the concentration dosage, reflected in units, milligrams, mics per minute or hour, and any specific instructions from the sending physician. So, again, this just goes to good documentation, right? Good, clear documentation of this is what I had, this is how much I gave, this is what was that, this is what the physician told me about this particular medication, things to look for. I would highly recommend, and I'm asking, and something that I need to be better at myself, if there's a medication that you don't have any idea what it is, don't roll out that door until, you're not gonna get a pharmacology class, but get at least a basic understanding. What does this do? What is its range? What is the norm? What's the expected dosage of this medication? What if, and what would you like me to do if this happens? If it's a pressure, what would you like me to do if things go this way or that way? And what kind of adjustments do we need to be made? We're gonna further talk about this with the other guideline we're gonna talk about. But having that conversation with the physician prior to leaving the hospital is an important, very important thing to do, rather than just rolling out. I'll freely admit I took a transfer about two months ago, and Robin was the nurse, and she told me the drug on this sick kid, and I didn't understand what she said, and I said, what? And she said it again, and I was like, oh, okay. I honest to God, didn't want to ask a third time. But I didn't know what she said. I didn't know what drug was. So guess what? I thought, that's okay, because it'll be in the chart, and I'll just look it up. I couldn't find it in the freaking chart. And so I started, to my best of my ability, what did it sound like she said? And I started looking, and I ended up finding it, and it it was a generic name of an antibiotic. It wasn't a big deal, but I thought how irresponsible of me to roll out the door with a medication dripping on a child that I didn't for sure know the name of the drug. I should have, if I had to set it down in front of her and say, can you write that out for me, please? Like, that's still better than walking out the door. I don't care. I look a lot more, I would look a lot dumber if we had an adverse event in the back of that ambulance from a medication that I didn't know for sure what she said it was, than I would ever look if I just said, write the spelling down. And I could easily say, write down how that's spelled because I want to read about it on my way down. And I've done that. Anybody guys ever done that on your transfers? Pulled up a drug and been like, oh, what is this? What does it do? Type of thing. You should be doing that, right? That's going to make your practice better. And the next time you get it, you're going to have a little better understanding. But yeah, it wasn't two or 3 months ago that I took a kid out and I was just like, that was stupid. That was a dumb choice it was a complacent moment. I didn't want to look stupid in front of Robin, who I've known for my whole practice. And she wouldn't have cared less if I would have been like, Robin, sorry, I'm in my 50s now, I didn't hear what you said, kind of thing. She would have been just fine with it. But please, please, please make sure you have a good understanding of the medications that you're in charge of, because the minute you walk out that door, you are in charge of continuing that prescription for that patient. So.
Braylee, one of the ways that I've always done it is I'll go in and I'll be like, they're on this, and this, and I actually will always say, have they been on this for a while? Are they cruising on it? Are they doing okay on it? And a lot of times they'll be like, oh yeah, he's been on it for an hour or two, and so he's fine, right? But if they're like, no, we just put it on and, anticipating the transfer or whatever, then I'll say to them like, okay, if something's to change, how would you like for me to address, how would you like for me to change it? So if his blood pressure goes up or down, if he becomes more conscious or less conscious, because it's usually blood pressure meds or sedation meds that are the ones, right? And so that's the easy way to be like, oh, super, well, if something changes, how would you like me to address it? And they'll be like, oh, if he wakes up a little bit, bump it to this, right? If his blood pressure gets crappy, go ahead and do this, right? Quick, easy way. Has he been on this for a while? Oh, yeah, he's doing great. That gives you some comfortability that he's not likely to change, or she, right? And if they're like, no, we just put it on, expecting you guys were gonna go, super. If something goes sideways, what does that look like and how might I fix it, right? And they'll be great about it. So.
I think to Kyle's point, when you're asking those questions, especially about titrating meds or how you want it to go and, what your trigger points are gonna be, talk to the sending physician.
Yes, agreed.
Right? Because a lot of times you get caught up in the round and round with the nurse and you're trying to get answers on that and, they're just offering up how they swag these medications and it's not from the source of the person that's actually sending the patient. So.
And half these nurses might be the first time they've ever put that
Well,
medication.
Sure,
We've got so many
take
new
the time to
nurses,
talk to
right?
the doc,
Yes.
Well, since Jeremy brought that up, and we're kind of getting the cart before the horse, but it's a good time to emphasize it. In the other policy, one of the things that it says is that, and we know this happens, I've done it, and by the way, I think you all should do this, but we know that we've made decisions to change dosages on medications. Brayla, are you listening?
I am, yes.
We've decided on our own to change what rate something's running at. Now, probably for good reason, always, right? But at the end of the day, Dr. Raskovich made this clear. You're not a doc. He or she is the doc. They prescribed a medication at a prescribed amount. That is not for us to change. Now, that doesn't mean it might not need to be changed. But you have that conversation in advance and say, hey, if something changes, how would you like for me to address it? That's exactly what we need. Or if en route to a hospital, you're like, I'm not happy with this, right? So I'll give you an example. A hypertensive stroke patient that we're trying to get somebody's blood pressure down to an ideal range. And if it's not happening, if you didn't have the conversation with the sending facility, what you should be doing is getting on the phone with the receiving facility and say, hey, know your target blood pressure was, whatever, how would you like for me to adjust this pump, right, the rate? Or, hey, we've noticed that this person's blood pressure on Levophed is now way too high. What would you like me to address it? How would you like it managed on the pump? So Dr. O's point is very clear. He recognizes that we need to manage infusion rates, but that's not up to us to decide. It's either because we've had a conversation in advance or we've made a phone call to make sure that we are doing what they're asking us to do. Because we are not doctors, and Dr. O made that very clear that day, okay? So,
he specified though, orders for any titrating of meds?
yes, conversations in advance of or before, yes. And that's not that hard to do.
And to this point, Jason's had conversations with the hospitals,
Yes.
that they have copies of these guidelines, which they are in huge support of and huge favor of, to the point even, you didn't say Dr. O took his to the hospital
Yes,
that he works
Dr. O
out.
took the infusion guideline, I asked him to put it in front of his nursing staff up there, cause it's brand new. And the gal up there's like, we should probably change ours, that's really good. So they took stuff out of here to do the IHC at Park City Hospital's infusion guideline up there. So, yeah, it's just another way that we need to tighten it up. So again, have the conversation in advance, right? Plus it makes you not look, you are a smarter provider if you say to the sending doc, hey, I notice he's on this presser, is he doing okay on it? Yeah, great. Okay, if something changes en route, how would you like me to address it? And they'll be like, oh, if he wakes up, this is always how it goes. Oh, if he wakes up, go ahead and put it to this, or, if you're a little worried he's too deep, you can put it to this, or if his blood pressure gets to this or to this, just do this, right? That's an easy, quick conversation. Every doc in the world, they have those handoffs when they do ICU to ER handoffs. Like, those are things that happen in hospitals all the time. Don't worry about looking stupid. You actually look smarter when you're like, hey, I notice he's on whatever. How would you like us to address it if something changes during the transport? That's all you gotta do. How would you like me to address it if something changes during the transport? They'll tell you. Then there's your orders right there. But don't do it on your own.
And it puts a perspective, anybody here ever worked as an EMT or a paramedic in an emergency room? Besides myself and Jason. Nurses do not change infusion rates without
Nope.
orders from a doctor. Okay, so the nurse who set it up doesn't just go in and go, oh, his blood pressure's high, and they make that change. They go in and say, here's what I've got, doctor whoever, and the doctor will say, okay, I want you to change it to this, and they will go in and follow the doctor's orders. The nurses don't make that decision on their own in the ER with the physician sitting at the desk. So I think part of what makes it hard for us is on our scene calls, we make those calls. We decide how much we're gonna give. We decide what's appropriate for the patient. And I think, which is great that we have that confidence, but when we are getting it from a doctor, it is a prescription. Okay, is it a prescribed amount? And we are not to change that prescription without some direction from the guiding physician, whether it's the receiving or the sending physician. I don't know if that puts it into perspective, but even nurses in the hospital, even whether it's on the ICU floors, it doesn't matter where they are, any changes made in medications to the patients come from the physician, not from the nurse. They may be the ones executing it, just like we will be, but those things need to happen with the conversation with the physician.
Braylee, you had a question?
Yeah, I've called, and not even about pumps, but I've called before to ask for medication orders, and it's always a nurse over the phone who's giving them.
They're doing that as approved by the hospital,
Okay.
so that's fine.
So if we call about a
That's
medication and we say, can we adjust it, and
That's
they're like,
fine.
yep, you're good, okay,
That's fine.
okay.
And all of this goes back to that bullet point we looked at, which is document, 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 right? If you make a change, if you give the nurse's name, fantastic. If not, say I spoke with the charge nurse of primary children's, this is what I explained to them, they said to change it from this to this. And make sure that we've got that documented in our documentation.
Rox, you had a question?
Just a comment, one of the things I would just check is how much time we have left on our drip too. One of the things in our toolbox is that we can ask for a new drip, a new bottle or a new bag of something.
Yep.
And then we can program it and still have the one
Can I
running.
get a couple bags of that fentanyl to go?
Right? I don't worry, you can trust me.
You only have one? I'll
Yeah,
take it.
but there are some that we take the drip fairly quickly. Propofol is one of them. You can go through propofol fairly quickly. So yeah, definitely make sure you've got enough, and if you're questionable, ask them to send you with a little bit more. I've never had any issue with them giving us a new bag of something or anything like that. So that's a good point.
You can anticipate that stuff up front too, because sometimes it takes a minute, right?
Right? Yeah, for sure it does, because it's gotta come down from the pharmacy, especially if they have to mix a bag or
That's what it
something
is,
like
yeah.
that. It takes a bit. It's not something they just go pull out of the Pyxis. They have to get that that stuff done, so.
Hey Braley, on your question too, there's nothing wrong with asking for a doc on the phone call too.
Yeah.
Like if you have something specific or it's out of the ordinary, or if, maybe even if you're not getting what you want from the nurse, and you can articulate it to the doc, just ask them. There shouldn't be any problem doing that.
Nope.
There's been plenty of time on a really serious patient where I've just said, hey Linda, it's Kyle, I need to talk to the doctor. And they just get the
It's
doctor.
just easier that way.
It is. And I've had times when I've explained my whole thing for 45 seconds, and I'm like, hold on, let me get the
Here's
doctor.
Dr. Nelson.
Yeah, and then you spend another 45
It's like,
seconds.
oh, hey Linda, I don't
Yeah.
have time for you right
Right?
What's a patient's shoe size? We're coding.
Exactly. What they eat last? How long ago was it? All right, any questions up to that point? Pretty clear with all that? All right, let's turn the page over. We're gonna go on to number 2 there, Mark.
I'm gonna hit just real quick
Oh,
on the
yes.
documentation on the pump settings. I'm working with Captain Romney on building an extra worksheet into Image Trend, similar to our RSI checklist, to where you could just click on that side tab. It'll pull up a sheet that'll have all the blanks. You can just fill out all your pump settings so you don't miss a couple or have to worry about where else do they fit in the report.
Easy to document that way. All right.
Let's see, I think we touched on the next one already. Titration adjustments, either at the sending or receiving facility, should be discussed prior to transport. And then documentation of vital signs is our next highlighted one there near the bottom.
I'm gonna add one other thing based on our
Yes, sir.
comment, sorry to keep hijacking your stuff. So
No, you're
one of the medics the other day, rightly so, said, hey, you and I both know we've had occasions where at the sending facility, I'm not gonna say who, like, it's a shit show, and they just want us gone, and like, there's a problem, right? Like, but I'm not gonna go to that doctor, I'm not gonna go to that nurse and be like, hey, because I don't wanna cause a problem. And he's like, so what do you want me to do? I need you to fix it. I'm like, great, no, I totally understand that. Here's what we need you to do. Load the patient, don't cause a problem at the bedside unless it's absolutely critical to the patient's immediate condition. And then any guesses what you could do?
Call the receiving.
Call the receiving. Be like, hey, late medic 53 with ambulance 52, we're on our way to your facility. After we left the hospital, we had some concerns about, I just wanted to check with you real quick. Should this propofol be running like it's tap water out of, no, it shouldn't be, okay? And they'll tell you, right? So if you, because they don't know any of the backstory, they just know what the med is and what it should be running at or whatever, or what they'd like to see it at. So if you anticipate anxiety where you're sending from, just load the patient up, get on the phone with wherever you're taking the patient to, and just be like, hey, we noticed the pump was running at the whatever med was running at this. Is this what you want them at when we get there? Oh, let me go check real quick. And they'll come back and be like, no, let's go ahead and put it at this. They'll say like, what is this vital sign, or how's the patient at the moment? And you'll tell them, and they'll be like, no, why don't you go ahead and do this? Again, don't do it on your own, and if you expect a problem, call the receiving facility. Fair enough? Okay.
All right. Are we down to the very last thing here? That's highlighted under doc communication, which we've talked a little bit about. But documentation of medication infusion details to include a complete set of vitals will be done at least every 15 minutes or more frequently based on patient severity and illness. And then an example there is when insulin is infused, blood sugar analysis will be done at the sending facility, Q 15 minutes or every 15 minutes, and again at the receiving facility. This came into play specifically on our call. We got a blood sugar at the hospital, I think it was 158.
Yeah, they showed us the monitor right as we walked in.
Yeah,
We
we're like,
just
"Ah."
took it, right, as they were walking out of the room, it's 158.
Yep. And they
So-
check it every hour after that, and so in our thoughts, we're like, we picked them up, they're good. They wouldn't check it for an hour at the hospital, why do I need to check it? Well, had we checked it en route, maybe we would have caught that, hey, it was 158 10 minutes ago or 5 minutes ago, now he's at 76, there's a problem here, right? And that's actually specifically what happened on the previous med error that had happened was a pressor, and they found, based on a good vitals assessment, that things weren't right, and we're like, whoa, there's clearly a problem with something here, and we're able to catch that and fix it. The error had happened, but they were able to address it quickly based on their good assessment and good patient care. So,
And they also, by the way, again, sorry to interrupt, they also took pictures of what everything was set at, awesome to have, like awesome to have. So it was a good thought to do. So again, use that iPad for what the awesome tool it is, so.
And they, and it was handled the exact same
Perfect.
way, so they were able to get that taken care of. But, so make sure that we're doing vitals. The way we need to look at that, it doesn't matter if the hospital would take them every hour. For us, this is a new infusion, right? And so when they start anybody on an infusion, they don't go an hour once, like Jason said, hey, they just get started on this or they've been on it a while? Because that makes a difference, right? If they've been on it for a day and a half, they haven't had any problems, then we can probably anticipate we're not gonna have any problems. But for us, we're switching from pumps, we verified everything, but it's a new infusion for us. And so we need to make sure that we're doing those vital signs. If they're really sick, it's just like you learned in basic. How often? Every 5 minutes. If they're stable, we can go every 15. But we need to make sure that we're getting those. And I dare say there's really not a hospital that we transfer from hospital to hospital that's less than a 15-minute, maybe from IHC to Davis or vice versa. But still, we should be getting a set of vitals somewhere of our own in between those transfers. So, any questions at all on that guideline? Seem like a good idea? Will it help you in your practice? I hope it does, and I hope that you guys don't find yourselves in the same situation that Mark and I found ourselves in. We're gonna pass another one out to you.
While they're passing that one out, can I make a recommendation? Have one of these near you at the computer station that you work on. And when you're documenting, when you're doing your narrative or whatever after, just glance at this and just think to yourself, because Dr. O mentioned this, like, did I cover everything in the patient handoff part in my narrative? Did I cover everything in the infusion management part in my narrative? Did I cover the during transport stuff in my narrative, which is basically that part 3? And then did I cover everything in the part 4? If you look at those 4 things in your narrative and just say, oh yeah, I addressed that. Oh shit, I forgot to have that quick conversation about that. I should put that in there. This will be a great prompt, which will improve the quality of your documentation. So quick sidebar about documentation. I'm, as stupid as this sounds, I'm an expert witness on an EMS case right now for a local EMS agency that's being sued for a wrongful death. They're gonna be fined, I believe, but they're not gonna be fined because of their documentation. If they were surviving on their documentation, they'd be in trouble. Luckily, everybody that documented surrounding the event, to include the ER that received the patient, the place that sent the patient or whatever, it paints a picture clearly that the EMS folks didn't paint, to be honest with you. And so I cannot implore you enough. It's a big wake-up call for me. We talked about being deposed the other day. Kelsey's been deposed 5 times already. You need to be able to write a narrative in a way that if we hand you your report 2 years from now, that you're like, oh yeah, I totally remember this call, like got it, right? If you don't, you're gonna really, really wish you had. We're running about, anybody know roughly how many EMS transports or EMS calls we run a week? Take a guess, ballpark it.
127.
Close, good for you, that's very succinct.
If anyone in this room was gonna know, it would be Alex.
150-ish a week, all right? Guess how many of those that we get a Grandma Act or a FOIA request for? Which means somebody, basically a lawyer, is putting their eyes on it.
30.
About 20%, about 20% a week.
Yeah.
Now, those don't always end up in lawsuits, they end up being settled or whatever, they're inconsequential, but roughly 30 times a week, somebody's reading your reports. And of those, I promise you, there's 5 a year that are gonna end up being deposed. And when you sit across from an attorney, make no mistake about it, they're looking for any chink in the armor to get their patient a settlement, all right? And yours might be supporting their argument they've got against somebody else, all right? But make sure you're writing a report. I will tell you this. Part of the complacency, you heard me mention it when I started, I think one of the places we're very complacent is reports. I'm imploring you, I'm begging you, not as the EMS battalion chief, not as a battalion chief, not as a boss, as Jason, 30 years plus in the business, please take 5 more minutes on your report. Write 5 more sentences, which makes 1 more paragraph than you might be making right now. That 1 paragraph might save your ass. All right, so especially on somebody that's critical, but I will tell you this, many of the patients that we end up getting sued for, or that we're involved with, aren't patients that you would have thought. They're not like, dude got shot with a gun by the cops. That's not who it is. So, I know it's hard, day 2, middle of the night, second call in the middle of the night, but please take 5 more minutes on your narratives. Do 5 more minutes of good documentation. I promise you, you will be glad you will. I'm gonna give somebody some props. If I heard Leighton Fire's being sued on a case, oh shit. Who was on it? Roxanne. Who documented it? Roxanne. Oh, we're fine. Have any of you read Roxanne's narratives before?
Yes.
We're fine. Yes, right? And you're like, holy shit, right? But, if you read one of Roxanne's narratives 5 years from now, you're gonna know everything about the call, right? Is it inconvenient? Yes. Will you be so glad Roxanne was your partner when you're named in a lawsuit? Yes. I had that happen in mine. Michael Sheets was a partner of mine. Michael wrote great narratives, thank God. It was an officer-involved police brutality claim. Got the cop's narrative, didn't get his ass off the sling. Michael's narrative got the cop's ass off the sling. All right? So be like Roxanne. Okay, you know what I mean by that, right? Okay. So whatever that looks like, please tidy up your narratives.
And I threw this in last time because as an officer, I do get to read at least all of my guys' narratives, that they do a pretty good job. But I've had some grammar and spelling matter. If you want to look competent when an attorney is reading your report, if you can't spell and you have run on a sentence that lasts this long with no periods in it, all they're looking for, what do you say they're looking for? A chink in the armor, something to discredit you, something to make you look like maybe you don't know what you're doing. And grammar and spelling are the quickest way. I read a report one time, he's not with us anymore, God bless him.
He's a sweet spirit.
But he typed in that he assessed the patient, ACEST.
Oh, gee.
Assessed, that was he assessed them. I don't even know how, that couldn't possibly get through spell check, at least run a spell check, right?
Is that an acronym?
Right? But like little things like that, an attorney's gonna have a heyday with. All they need to do is be like, did you graduate high school? Because it doesn't look like you did. What are the requirements required to be an EMT? What do you have to be a paramedic? You can't, basic spelling. Don't give them a reason to be able to pry that door open on you and discredit you, because you may be a fantastic caregiver, but we can make ourselves look dumb by poor documentation.
You gotta, go ahead.
Yeah, I just wanted to add that there's that awesome training that Dr. O does,
Yeah.
the elegant documentation is really good.
Yeah.
Good point. And it's on the Target Solutions, I believe.
Look, I know none of you, when you got into the business, thought, I'm gonna be the best damn report writer ever. Like, none of you, that didn't cross any of your minds. I will tell you, honestly, I can tell from reading somebody's report how good a caregiver you are. I can. And if you want to set yourself apart, learning how to write is real important. I can't emphasize it enough. I know some people graduated from Leighton High School. There's a T in there, by the way. Yeah, spend some time. 5 more minutes, 5 extra sentences, and maybe, as Kyle said, maybe 5 periods. All right.
Even if they're the wrong place. just go.
So,
Jeremy made fun of me the other day because as I was typing, he was like, I don't know how I can tell how old you are because you double space between every period. I'm like, that's how I was taught how to do it.
so.
Period, space, space. What do you
It's
say,
still
Ross?
APA, isn't it?
In fairness, I was deposed once as a bystander, and I left that room even questioning whether I knew what my name was. I
Right.
never, ever have to do that again.
Yeah.
Ever.
The only time I've been called to court had nothing to do with the EMS. I was in 9th grade for a teacher that kicked a kid out of class. And even then, they were brutal to a 9th grader. Like, there were 5 of us to walk out of there almost in tears. Like, they're not your friend. They want to win their case. And they don't care if you lose your job. They don't care if yeah, they'll make you. Yeah. But they don't care. That attorney couldn't care less if I have a job tomorrow. He wants to win his case. And so make sure that you're, for lack of a better word, crossing all your Ts and dotting all your Is, because, and writing good, comprehensible things, so.
Might think.
I think we've hit enough on it. I'm just
Yeah.
gonna mention one last thing on the documentation, right? It's not good enough to just say, we copied the hospital settings, right? Cause as far as we knew, Kyle and I, we copied the hospital settings,
Right, sort of, with our own.
but we didn't, right?
With my own bad.
So make sure you put the numbers in on your narrative. Like I said, we're getting that sheet put together, so hopefully we can just fill out those numbers. It'll all be documented clearly.
Yeah, that'll help. Okay, we're gonna jump into this, and we're just gonna hit the red sections. That doesn't mean I don't want you as a crew to go through the entire guideline, okay? This is not new. We have addressed this in the past about, oh, what do we do with paramedics and ALS transfers? This is a updated version of what's been, and it's better, and it comes from Dr. O. The first thing I wanna hit before the red section, if you look under procedure, one change that we're making there, it says upon receiving a transfer request from a hospital and or medical facility, this guideline actually will only apply to transfers from hospitals. Anything outside of a hospital, if it's We Care, Tanner Clinic, any of those, is not considered a transfer, right? That's a 911 call, it's a scene call. So this is only going to be considered from transfers from facility to facility as far as hospitals go. So that'll be changed. Next, jumping down into the red, if a sending facility requests lights and sirens due to patient severity, both units, in bold on both there, will safely respond with lights and sirens to the hospital and then to, this should say the receiving facility if the patient condition warrants. Okay? I will be the first to say, when I was told you need to run code on STEMIs to IHC, I was like, seriously, they're already in a hospital. I'm gonna run from 52 all the way down through town, pulling there to pick a hospital up where I'm gonna spend 10 minutes and trying to even get the patient ready. Well, yes, this is from Dr. O. He was the one who said on the STEMIs, yes, you will do that, because we asked him, like, do we really need to do that? And he was like, yeah, if the doctor wants you their code, you're going code. There have been a couple of other times that were not STEMI calls when they have requested a lights and sirens response, and that's how we are expected to respond. Okay, any questions on that? Okay, Ron?
We had one 2 weeks ago.
Yeah,
I think you were off, but we had a transfer. It was a STEMI coming out of IHC, going up to McKay. They didn't have where they were going at McKay yet. We get there, the plan was to send him up to the cath lab. Apparently the cath lab wasn't gonna take him for whatever medical history. And so we still responded lights and sirens down to the hospital, and then it's a quick question to the doc, like, hey, normally our standard is we go lights and sirens up to McKay, where we're going up to the ICU now, do you want us going lights and sirens? And he's like, oh no, you don't have to do that, right? Just a quick 2-second conversation, they'll clarify all that, right? Even if they are going up to the cath lab, hey, we normally go lights and sirens, is that what you want? Yes, or no, right? And then just document that.
I'm not gonna jump straight to the red on the next one because this section is important. How many in here have ever run as an ALS transfer and then once you got out to the truck bay, you loaded your patient and you kind of looked in and were like, you guys don't really need paramedics, do you? Okay.
Just on oxygen.
We've done it, I've done it, and we've made that decision. There's a few things that are wrong with that. First being, we've already talked about this a little bit, but we need to key in on it. That conversation is not our decision, just like changing the medications. It's not our decision to decide that the physician is wrong, okay, that they don't need ALS, without having a conversation with the physician. The EMTALA, which is a legal document, which is between doc and hospital to hospital, will say that that patient's going to be transferred with an ALS responder. If we change that, we are changing the nature and of the EMTALA itself. The EMTALA has to be changed as well. So we cannot just make the decision, you don't need me. Even if you've got the most confident, advanced guy that you have complete faith in, doesn't matter. That conversation has to happen between us and the facility before we go. Sometimes that request comes from the receiving facility. Primary Children's is famous for it. I asked the doctor just 2 or 3 weeks ago. Walked in and said, because we didn't feel like the kid needed to go ALS. And I said, hey, did you request ALS or was it the receiving facility? He said, no, it was primary children's. I said, okay, thank you. And we walked out the door, okay? And we sent him with a paramedic, all right? That doesn't necessarily mean that we always have to go with 2 paramedics, but that a paramedic will be in the back, not just driving the ambulance, but a paramedic's gonna be in the back providing patient care.
So let me clarify something real quick. We all know that at IHC Layton, there's docs that moonlight from down in Salt Lake. One of the refrains, it's been said to crews before, we don't, like, the one that's the patient's on oxygen only, right? And they'll be like, we don't know what you're all are capable of, that's why we said ALS. So it's absolutely appropriate, not if you're trying to get out of doing work at 2 in the morning, I keep saying 2 in the morning, and I know you're not doing this, but I just wanna clarify. If you get there and that patient is clearly within the scope of our AMTs and they're comfortable with it, it is totally okay to go up to the sending doc and be like, hey, just want to clarify something real quick. I noticed he's just on an NS line, which is really within the scope of our advanced folks, and they are very comfortable taking that. I just want to double check real quick. Are you okay if we send them just EMT only, or advanced EMT only? And they'll be like, no, yeah, that's totally okay. I didn't know what y'all are capable of, and that's totally fine. Then in that case, great, right? They might be like, I'd really rather a paramedic went. Okay, great, yeah, not a problem. But we cannot make that decision ourselves under the canopy. Now, if there's a medic on the ambulance, then right here in the guideline, you can absolutely equip them appropriately and have the medic transport them if that's appropriate for the patient's condition at the moment. That's fine. But if a medic is requested and we don't specifically get approval to do it from the sending facility, otherwise, we are not on our own gonna make that decision. When Dr. O heard that that was happening, he clarified quickly that that would not happen, and he recognized there's occasions that we can do that, but his point was very clear. His point was very clear. If that decision, that conversation needs to be made before that we are not doing that ourselves, that can be done if a physician agrees to it.
And to
Copy that?
But if a medic's on the ambulance, we still have to throw another body.
That's what I was just gonna say, we have to have
That's
2 in the back,
policy.
but
We
not
have
2
to have
medics.
2 in the back,
We do have
right?
to have 2 in the back.
So, and you know, Ben said to me, dude, I'm not sure I wanna jump through that song and dance with the doc, and who knows what kind of mood he or she's in that day, and like, I feel like I'm just gonna send my medic. Great, send your medics. It might be, Kyle said it yesterday, by the time you have that entire conversation and change in the teleform, you could be halfway to primary, just go. We have 3 medic units, we have more paramedic units in this county than we've ever had. Sometimes it's not worth the fight, it's not a fight. Sometimes it's easier just to go. And might you end up on it, as medics, might you end up on a call you don't need to be on, quote unquote? Maybe, right? Let me tell you about one I had. I had a patient, was sure I didn't need to go on. I didn't even ask the ambulance folks. I'm like, you guys are gonna be totally fine, and this guy's stable as can be, until he wasn't. He stroked halfway between here and Salt Lake, ended up having to divert to Lakeview because he lost consciousness and lost his airway in the process. And I got a phone call from Dr. O. Hey, transfer you were on, something went sideways, what's the story on it, all right? So it's easy to convince ourselves like, oh, we've got good people, oh, he's fine. I wasn't gonna change that guy's stroke, I wasn't gonna change what happened to him, but it did not reflect well on me and Layton Fire. So if you get an ALS call, you're welcome to change it if the doctor approves it, if it's appropriate for the patient's condition and our scope, but otherwise, just take the transport.
And most of the time, these physicians are going to lean to extra caution.
Yep.
There's a couple, Dr. Bass, love him or hate him, I don't really care, but he always is, I'm worried about just what if. And I walked out of the big going, well, we can what if this to death, all day long. Like, you know what I mean? But the fact of the matter is, if that's his concern, maybe, you know, I've had him say, sometimes when they come off these drugs, they can have a seizure. And I look it up, it's like 0.01% of the time a patient has a seizure. I'm like, you gotta freaking be kidding me.
That's a poor example, Kyle.
Right? Right? But you know what I'm saying? I mean, it happens, and I'm just saying, I've been that guy where I've been like, come on, we can what if things to death.
Right.
But the fact of the matter is, they will generally lean to, extra caution rather than not. And so if they say, nah, you know, I know they're just on oxygen, but I prefer to have a paramedic in the back, we're not gonna sit there and challenge that, right? We're not gonna get into an argument with it. Great, that's what we're here to do. This is our job, and they are the physician, they've asked us to go, we're gonna go. Part of having that conversation, and I think to me it's important, and I think it makes a difference, and my guys will attest, how often do I talk to you about building relationships with hospital staff?
There we go.
All the time. And part of that is because having that conversation is so much easier if they recognize a face with a name, you spend some time around them, they know you're competent, the amount of, you know, when you come in, your pass-offs are clear and they're concise and the care you've given is good. As you build that relationship and they get to know you on a first name basis, those conversations are much easier to have. I could go up to Dr. Anderegg very easily and be like, hey, Dr. Anderegg, here's what I'm thinking, and she's gonna be like, great, or I've had times when she's been like, no, I'd still rather have you go with them. I had a full arrest one time of a guy that ran out of the ER and jumped the fence and got hit by a car. And we were sitting in the parking lot, watched the whole thing happen, drove down the thing, picked him up, drove him back into the ER. He was like everything was broken in his whole body. And I walked in and I told me, thinking I'm the smart paramedic, hey, Dr. Anderegg, this guy's done. You know what she did? She kind of gave me a little pinch on the neck and said, you know what? He just ran out of my emergency room. We're going to work here. And I was like, I'm an idiot. Of course we are. What can I do for you? Would you like me to do compressions? You know, but the fact of the matter is they know what they're doing. And they've never in my reality, I've never seen one of them send ALS as a punishment like, I'm gonna screw latent fire and send a paramedic today. That's not their intent. Their intent is patient care and giving the best patient care from here to wherever we're getting them. And that's our goal as well. So let's just make sure that, like I said, if you need to have that conversation and it makes perfect sense, have the conversation. Otherwise, let's go as requested and get the patient to the hospital that they need to get to safely. Which jumps down to the next section, which is, we talk about those patients that maybe don't need us. What about those patients that we're like, holy shit, this guy's sick? This guy, you know, Jason, I'll let you tell the story, but he's got a very good example of when he's turned down a patient.
So you can see on there, it says if you're not comfortable because of the patient's condition, which might mean multiple infusions, wonky ventilator settings, or a bad airway, person's trying their damnedest to die and they just want them to die in our rig on the way to a hospital instead of there, whatever, right? It's totally appropriate for you to say to that sending facility, hey, we don't feel we can safely transport this patient right now. So I had myself and Mark, Captain Hoyt, and we had our partner at the time was John Pettyjohn. All three of us, flight paramedics, veteran flight paramedics, 20-year plus people here. We walked into the ICU at Davis Hospital one day, and we looked at one another and went, yeah, no, we're not done. Right? Like, could we have? Maybe. Should we have? Hell no. And so I walked out, found the doctor, and I said, you really need to call for a helicopter on this patient, right? Had a crew the other day that was at the hospital, and I could tell from the notes, the patient was super, super sick. Sent the captain a text, and I just said, hey, if you need to go with the crew, by the way, absolutely go. If you need to call a flight team, that's what they're there for, don't forget. Happened to be that Jeremy was on duty that day at AirMed. He wasn't happy with me, I'm sure, but they went with the patient, all right? There's a few times that they will call AirMed because the patient's that sick, but it's a bad weather day and AirMed can't fly. Patient still needs to go, we'll get the transfer. I'd say it's about 20% of the time, AirMed has said, we'll do a ground transport with your ambulance and go. But a lot of times it's like, oh, AirMed can't go. If you ever hear the words AirMed couldn't go, that's usually a clue that they thought the patient was sick enough they probably ought to go with the flight team. Have that in the back of your mind that if you get there and you're not comfortable taking the patient, all you gotta do is say to the physician, hey, we don't feel like we can safely transport this patient right now. We'd like some help. That's what the team's there for, right? Use them, so.
These conversations with the physicians, right? They can be intimidating, right? We all know who we are. Some of us aren't as good with words as others. So on our crew, if we have this situation where we need someone to have a conversation with the physician, it's not gonna be me, that's gonna be Captain Hall, because he knows the physicians better, he's been around a lot longer, and he's better with his words than I am, right? We know who we are.
Unless he's off.
Yeah.
And if you need to, call Jeremy.
Yep.
I've had a crew call, Roxanne called me once over there to Davis Hospital. I walked over in my gym clothes, sweaty, I'm on the elliptical. And I walked in the door and she's like, we can't transport that person. And this dude's throwing security people around. And I'm like, oh, hell no, we can't transport that person. And I'm like, why haven't they sedated him? She's like, they won't. And I'm like, all right. So I went over and I found Dr. Burlbach and I'm all, we're not transporting him. And she's like, well, he needs to go. And I'm like, I understand that. We're not transporting him. Cool. she's all, well, what do we need to do? I'm all, you either need to give him a social intubation or you need to sedate the shit out of him. She's like, well, what do you want to do? And I said, we'll use some ketamine if you're okay with it. She's like, are you comfortable with that? And I said, very comfortable with that. And she's like, well, how much do you want? And I told her how much to give this guy, and he became chill AF. Remember this? Security dude was pissed that they'd been fighting this guy for 2+ hours when all they had to do was give this guy 50 of ketamine. So if you need an advocate, that's what Lance is for, that's what Jeremy's for, that's what I'm for. Don't hesitate. If Kyle happens to be off and you're acting in and you're like, what do I do? Phone a friend. That's what he's there for, right? So don't hesitate. We can have those conversations if we need to. Just because you're there, don't put yourself in a situation that we can't dig ourselves out of. Fair enough?
No.
Okay.
In the very last section, we've actually kind of really talked about already, but it goes back to that. If they ask for an ALS response, they will always be transported with at least one paramedic on board. Under no circumstances will the A&P or paramedics dispatch decide and then underline on their own, which the caveat back to that is the conversation has to happen, right? We don't make that decision under the canopy, like where we walk out, and I've done it. I've done it more times than I probably can count. Where we walked out and been like, you comfortable with this, Allison? 'Cause there's nothing I'm gonna do, right? And we send them only to find out, here I am now going, man, that was the wrong decision for a number of reasons. Dr. O is adamant about it, okay? I don't think it's gonna happen that often, to be honest with you. I don't think, I've had a couple people be like, that conversation with the doctors, how do you think that's gonna go? I don't think we're gonna have that many conversations. This is the exception and not the rule. It will happen very infrequently, but when it does, you've got a little bit of latitude and freedom to go ahead and have that conversation, right? And
So I'm gonna add to that real quick. We already told you, we gave these to the hospital so that they can start looking at and give us some feedback. We're meeting next month with Dr. O, myself, Kyle, our admin, the physician directors from both hospitals, and the EMS liaisons from both hospitals. We have this topic and a couple others to deal with. When we have this topic with them, I'm gonna tell each of the directors, so the physicians, so the docs that's over the docs at the hospitals, our ask of you is this: please make sure your physicians and your nurses know that we may have occasions that we're gonna come to you and be like, hey, we need a helicopter. There's also gonna be occasions that we're gonna come to you and be like, hey, really comfortable sending this with our ambulance folks. You need to know that we're going to have those conversations, why we're having those conversations, and that you need to be amenable to both of those conversations. So they will be. They're super good dudes. Chris Andrick is the one for Davis Hospital, and Gabe Clark is the one for over here. Great people, and by the way, they're grateful for us. They say over and over and over again what great work we do. This actually elevated our organization in stature with them, that we were able to identify a system problem that we needed to correct it, and did it in a way that was transparent to them. Like, hey, we had to fix something, this is what it is. How do you feel about it? What do we need to know? So like, we've elevated ourselves even more with them. I'm gonna leave you guys with one last thought. You know that we do the AirMed thing. We, a couple times a year as the admin, I'm part of the admin team at AirMed now, we do a SWOT analysis of all of the bases. What are our strengths? What are our weaknesses? What are our opportunities? What are our threats? The Davis base for the last 2 years, the #1 threat to the Davis base isn't AirLife Utah, it's not Life Flight, The very top of the threats to the Davis base is Layton City Fire Department EMS transports. All right? We take transports out of Davis Hospital, then in almost every other place is a flight team. That's a huge hat tip to you. Our flight team recognizes that that affects our flight volumes out of here. They'll turn and look at me and be like, huh, how do you feel about that? And I'm all proud as shit. I'm proud as shit that we're affecting the Air Med base, because that's the work you all are doing, all right? So keep doing the good work you're doing. They recognize it. Dr. O knows it. Admin knows it, right? I cannot say enough about the occasions that we had the med errors. They were handled perfectly by the crews, all right? It says a lot about you, our organization, that people can feel safe. Now, you heard me say it earlier. For the 2 that I know about, I know there were some that I don't, all right? If you are a person that dispenses meds, you are going to make a med error in your career. Do not fear it. You will never, ever, ever get in trouble for making a med error unless you do it on purpose. If you're like, I'm gonna paralyze the shit out of that asshole and have a conversation with him. That might not go well, okay? But if you do it in the course and scope, I've done it, I've had a med error, no harm, no foul. We look at our system, we look at what caused it, and we'll fix the system. If you hide it, that's when we have a problem. So, and I know we won't, because we've seen evidence that it's gone perfectly. So, really proud of the work you guys do. The one thing I will add, it's not highlighted. Years ago, when we started our paramedic program, those of us that were part of the original group decided when we were going PMA, we were going double PMA all the time. And our reason for that was we all wanted to learn. We all wanted to be there to support our partner. We wanted to make sure that we delivered great patient care to the hospital, because we had a lot of naysayers. I'm being very honest with you. The people said, Layton Fire can never do paramedics because you're not cops and sheriff's deputies and we're the smartest people in the world. And we showed them that we could. But we went to great lengths to do really, really good patient care. Over the years, we've migrated away from that. So here's my ask. When you're on a 911 call in town, call volume depends, maybe, or whatever, but if you're going PMA to the hospital, jumping back and go both of you to the hospital. Maybe it's that one of you makes a phone call while one of you is helping one of your AMTs with an IV. Or it's because there's 2 of you there to bounce a medication off of with one another. Or whatever, right? Whatever. You've got a new paramedic learning from another paramedic. Right? You can't possibly cover everything you're going to need to learn in paramedic school. Right? The more touches, the more time you have in the back, even if it's with a paramedic partner, on that yawner diabetic that you probably didn't need to be on, until that one weird wonky thing happens that you were really glad you were. Even for the learning part of it, right? So my ask is, when you can, I consider you and encourage you to go double PMA here or up to hospital. If you need to go double PMA with a patient to Salt Lake, then by all means do. All right, but part of elevating and kind of re-examining our paramedic care is, I think we're better when we have more people in the back of our tiny little transport ambulances, because one of them's broke down almost. But more eyes, more conversation, more good learning. Maybe it's just that the both of you are sitting in the back looking up the antibiotic that Kyle talked about, and you're both learning about the antibiotic, and you're like, well, if we overdose him on that, he's gonna shit all over the gurney. Okay, whatever that is, right? So just do those things and learn those things, okay? So that's my answer.
All right. Any questions on anything we've talked about, concerns? I'm gonna just add on to what Jason said. I thought it was I sat in a meeting this week with, I'm the PEC, which is the Pediatric Emergency Care Coordinator for our place. And we have quarterly meetings, and Tia Dixon, who's down at the U, or Primary Children's, is kind of over things. Anyway, she did a whole thing on high flow oxygen, and was like, and as she's talking to people, she's like, now most of you don't know what this is, but we found out that it's really helping us keep kids from getting intubated and da-da-da. And she sold all the things about, but don't, you know, I just want you to know that it's out there and all. And I sat there and I was really proud to sit there and think that, you know what, I know exactly what it is, and we carry it, and we do it. Very few agencies, as simple of a thing as something like high flow.
I think we're still the only ground-based fire that's transporting with high flow.
I think so too. And there were a lot of people asking questions about it and things like that. And I thought, you know, that again, that's a hat tip from Dr. O, to Dr. O, that he is wanting us to have these things, that we can do these things. We are transporting, any other kid that was on high flow other than here is going to get on a helicopter. And we can take those kids and manage them really well, really, really well. So, like I said, just lessons learned for me. It doesn't matter how long you've been doing this. Please don't let complacency creep in. Trust is a wonderful thing until it's not, right? Mark trusted me. I trust Mark. I let Mark down, and it kills me. One of the examples that I said is the importance of, we're going to be the ones, if I'm taking the patient, I'm setting that pump up, is no different than who checks your air pack for you in the morning. Would you trust Abby to do it? You think Abby could do it? Yeah, and she may check it. She might be like, hey, I checked it for you, right? She'd do a great job. But the fact is, that's a life safety piece of equipment for you that you want to know, if my life depends on it, I'm gonna be the one that checked it, okay? That same attitude ought to be given when we're setting these pumps up. If I'm the medication, if I'm the guy administering that medication, I'm gonna be the guy that sets that up. I'm gonna be the guy, I'm gonna double check it, like our guideline reads, with a nurse. I'm gonna double check it with my partner. We're gonna make sure that it's dialed and ready to go, but at the end of the day, I didn't hand that to Allison. I trust Allison and say, Allison, set that up for me. And then she tells me it's good to go, and I just go. And that's not a knock on Allison's ability to do it. It's just the fact that I'm responsible for delivering that care to that patient, and I'm going to be the one that sets that up and does that. So, as advanced, I hope you don't feel like we've taken something away from you, or like, oh, that sucks. Like I said, it used to be innovation, used to be an advanced skill, right? And we trained on it, right? We used to train on innovations with our advanced. I practiced even as intermediate, a lot of tubes here. But guess what? When we went on the full arrest, I was not the guy throwing the tube. The paramedic was. He'd spent time in the OR. He'd thrown a ton more tubes than I was. It actually kind of blows my mind that was ever an advanced skill, because they never got, outside of throwing a tube in class, they never were on a real live body before. So, but the fact of the matter is, train on them. I hope our crew continues to train on them. I hope you know exactly how those pumps work. You're welcome to look over my shoulder, look over Mark's shoulder, and once the pump's done, ask some questions if you have questions. But the ultimate responsibility lies on the primary caregiver to make sure that that's going to be correctly delivered to the patient. So I hope you never, ever, ever, ever have to lay in bed at night wondering if a 12-year-old kid that you were responsible for is possibly suffering, could possibly die, could possibly have a long-term consequence based on something that you did because you were complacent. I cannot instill that enough into you, how it was the most awful feeling I've ever had in 22 years of being, to the point where it made me say, I thought of everything. I'm like, maybe it's my time to go. Maybe I did. Like, have I passed my point of being effective? And no, I haven't. But all those things ran through my brain because I did something that I thought I would never, ever, ever do. And so please learn from that. I hope you will. I hope my error will make you better in your practice. I think these guidelines do nothing but make us better. I'm grateful for Dr. O. I'm grateful for Chief Cook, Chief Mon, Chief Stell. The way this was handled, the way they handled it with us was awesome. And appreciate you guys being here.
I'm gonna mimic everything Kyle just said, and then, like we mentioned, we got lucky. We don't want you guys to run off of luck either, right? Eventually, everyone's luck runs out.
Yep.
So let's follow these guidelines and make sure that we don't have to rely on luck for good patient care.
These two are a good example. Thank you, guys.